So we just heard Rakiji talk about cognitive vitality and dementia and what it is not, what we can do about it, and so on. And you'll find several of the themes that she. Uh, can you all hear me properly?
Yes.
Yeah, good. So you'll find several of the themes that she addressed will flow into this lecture, into the next lecture, and so on. So there's a lot of commonality and overlap of these topics, as you'll find out. So in the next 30, 40 minutes, I'm going to address what we call elder care and geriatrics, and I'll go through and define those terms. And the objective here is,
Sorry, Mukunji, there is some rubbing noise. If nobody else is speaking, maybe you can put it on mute. And yeah.
thank you.
Thank you.
So I'll start out by talking about the objectives of the course today. First, we'll talk about geriatrics, and there are also a couple of other related terms that I'll define to you in elder care. So give you an overview of what that is. So when you hear people talk about this, you understand what they're referring to. And then describe ways to approach and deal with these issues when we're caring for our aging family members, as Maji is doing right now, and as I had the privilege to do for my father very many years ago. And as I mentioned, was there a question? I think I saw a hand raised. I guess not. Perhaps if you have questions, maybe you can note those down, unless it's important to understand what it is, and then we can discuss it at the end of the class. Maybe that'll make things go a little faster. So as I mentioned, when we talk about aging, the role of the caregiver is sort of almost inherent in you can't talk about one without the other. So talk about that and where we are with the caregiver role today. And then hopefully by the end of this coverage, we'll leave you with a body of knowledge and understanding, or at least a first glimpse, but you can go back and review material to understand things better, an understanding of the fundamentals of these topics, so that you can address them in your own friend circle, with your families, and also the main reason that you're with the CHT program, as to how you can utilize this information as you go forward and do community service. Okay. And at the end, I'll provide you a list of resources that you can go back, links that you can go back and read more about. We'll barely graze the topic in the time we have. And so depending on your interest, there's a lot more you can do in terms of learning and reading. Okay. So let me start out with a bunch of facts. The National Alliance of Caregiving in the US and the AARP organization, every 5 years, they put out a research report on caregiving in the US. And this report came out, this latest one, about a year and a half ago in May of 2020. And I've taken some of the data that I'm going to show you from this, and some from the Alzheimer's Association, and so on. The facts are that there are almost 53 million people in the US today, I'm not looking at the whole world, who are primary caregivers for people, primarily older people, adults, but also some children who have disabilities, individuals who are recovering from surgeries and illnesses, and those coping with Alzheimer's and other chronic diseases. So you could either have an acute disease, overcome it completely and get back to quote unquote normal before, or you're dealing with, you're in a situation where you have to deal with something that's chronic, it's lifelong, and sometimes it's chronic and progressive, so it keeps getting worse in the sense that it reduces your abilities as you go along in the time you have left. And so you need people to help you. You need people who can care for you. old while bringing up their own children. 10,000 people turn 65 every day in the US. So the population of senior citizens is growing in leaps and bounds. And there are almost 1,750,000 adults who live with a disability like autism, right? And they live with parents or another family member who's themselves almost a senior. So aging and caregiving kind of become inextricably mixed after a while. And so then you ask yourself, for the people who are being cared for, what happens if that caregiver was to go away somewhere? How do you prepare for that? How do you plan for that, right? So that's one of the things we want to be talking about and thinking about. Now, we've talked about Alzheimer's quite a bit in Dr. Raki's lecture, but a few topics to discuss here. Dementia, as she mentioned, is an umbrella term for a bunch of symptoms that are related to cognitive decline and the inability of us to handle our daily activities of living. Alzheimer's currently is expected to triple by 2020 from where it is today. 4.7 million patients in 2010, about 6 million living with it today in the US, and expected to go to almost 14 million by 2050. So you can see that the numbers of people who are dealing with Alzheimer's in a population that is aging is increasing, which is no surprise, but the numbers are quite staggering in their own right. And this is not counting other illnesses, chronic illnesses like heart disease, and so on and so forth. According to the CDC, Alzheimer's is the sixth leading cause of death in the US. And I'll talk about more about the impact through the pandemic in a little bit. Okay. And so when you look at the population that's older than 70 in this country, about 15%, a pretty large number when you think about it, has dementia. And some numbers, I've read some statistics that say that in the population that's over 90 years old, there's close to 50% chance of some level of dementia in patients. So the older you are, the more likely it is that you have some form of dementia in whatever level of seriousness that it has. Okay. I'm going to give you quickly some data that Alzheimer's Association just released about 3 or 4 months ago in a special report that I can give you a link to if you're interested later on. As I mentioned, more than 6 million people are currently living with Alzheimer's in the US today. But what is surprising is that over the past 2 years and through the pandemic, diseases related to dementia and Alzheimer's have increased 16%, which is much higher than deaths, of course, leaving deaths due to COVID aside, much higher than deaths due to other illnesses. Right? 1 in 3 of people who are over 65 is going to die with cause related to either Alzheimer's or some other form of a illness leading to dementia. While we've made progress on the medical front, for example, between 2000 and 2019, deaths due to heart disease have decreased almost 7.5%. During the same time, deaths from Alzheimer's have increased 145%. So you can see clearly that this is becoming a societal problem in addition to a problem for individuals and families. In fact, now they say that it kills more people every year than breast cancer and prostate cancer combined. And it costs money, right? Whenever we have illnesses of these, it costs society money, it costs us healthcare money, and so on. It cost the nation $350 billion last year. It's going to be more this year. And they estimate in another 20, 30 years, it's going to increase $1 trillion in terms of cost for looking after the care for people with Alzheimer's. Okay. And as I mentioned, there are a lot of caregivers. Most of them are unpaid. Almost all of them are unpaid, right? Majority of them. Over 11 million Americans provide care for people living with Alzheimer's. This is of the 53 million that I talked about who are caregivers. And they provide an estimated 15.3 billion hours every year, valued at $257 billion. Okay. So clearly, we have reached a crisis of aging and caregiving where we need more people, we need more help, we need assistance of different kinds. There's a growing need of growing population that needs full-time 24-hour personal care. As Mahaji is mentioning, family members take shifts to make sure there's 24-hour coverage. Right? In the US, they estimate that there's one specialist for a disease for every 20,000 older adults living with severe chronic illness. We'll talk about palliative care and hospice care in a separate lecture, and I'll tell you exactly what those mean in the May-June timeframe towards the end of the program. But there are only 1,600 hospital teams across all of US that provide palliative and hospice care. A severe shortage of that medical specialty that we'll describe later. And there are only 18,000 physicians like Rakiji, who you just met, and like Neeluji, another Sukham colleague who you'll meet later, who are palliative care physicians. There are only 18,000 in the country. So there's a need in this country, not only for specialists of different kinds, medical specialists, but also for trained amateurs like you and me who can provide effective caregiving. So this topic of caregiving and aging is very relevant to anybody who's thinking of doing community service and also for just general knowledge in the society that we live in. Okay. So with that, I want to cover the topics that elder care. Yes, Sangeetji, you had a question. Sangeetji? Perhaps not. Perhaps I just misunderstood. Sorry. I'm going to define three terms: gerontology and geriatrics, and one more term, and then put that in context. So when we talk about aging and elder care, there's a science that studies the social impact, the psychological impact, cognition, as well as the biology. So in addition to the medical aspects of aging, all the other issues that impact society and the way we live and work with each other is covered under the science of gerontology. Geriatrics is sort of a complementary medical specialization to pediatrics. So geriatrics is the branch of medicine that's specialized in older adults as opposed to young children. And I know many medical doctors will say, I would rather not answer this question. I don't think I'm qualified. Go see a geriatrician or go see a pediatrician. They can help, because branches of medicine are becoming more so specialized that you almost need to go consult a specialist in getting old, which is what geriatrics is, right? So that's a branch that's growing. There's a third term that is important to us as the Indian South Asian diaspora who live in this country, and that is gerodiversity. And this term suggests to us that our cultural heritage, our social structure, our traditions, our language, the way we live is a very important thing to consider as we consider our issues of aging as we grow up. Okay, so the gerodiversity, the study of gerodiversity is a multicultural approach to study the issues of aging. And so it provides the basis for which the medical and the psychological, the neurological, and other medical specialists uh, treat adults, because they have to understand the system in which we live. Have to understand our ecosystem, which includes not just where we live, which city, and so on, but our cultural identity, our heritage, the way we interact with people, what our social environment is, which communities do we live in, how does family play a role in how we live and work, and what our significant relationships are between one another. So understanding the holistic nature of a person, of a family, and how they live is essential to provide the proper treatment and the proper recommendations for treatment as we grow older. So the science of gerodiversity is going to become increasingly important in a globalized world such as ours. Okay, I'm going to spend a little bit of time now talking about a few issues of growing older, and these are can be listed in about 8 or 10 uh, what are called principles of geriatrics that were developed by a hospital system in Atlanta. I believe it was the Ebony Hospital System. And essentially, they say the first thing we have to understand is that aging is not a disease. Aging occurs at different rates from one individual to other. And even within me as a person, different parts of my body, different organs may be aging at different times. Aging alone does not cause symptoms. Aging increases susceptibility to many diseases, but at any given age, pick a number, 75 years old, you find people who are very ill and people who are very ill, very well. So aging is influenced by a variety of different things: environment, genes, lifestyle, access to what's needed for healthy living, access to what's needed for socialization, access to what is needed for companionship, and so on and so forth. Right? As we grow older, when we fall ill or when we develop conditions, we don't just have one thing going on. Typically, for a senior who's unwell, there are 6 different conditions that they're being treated for. And these medical conditions they can be chronic, meaning it's long lasting. It can be acute. It can be very serious for a while and then completely go away. There's multiple things happening at once, and multifactorial things, meaning what happens for one ailment and how you treat it impacts the other ailment. And there's the interaction that Rakiji mentioned that happens, right? And I discussed this in my first talk on healthy aging. The goal of geriatrics is to maximize the quality of life of a person and the functional ability of a person. How best can you make an older person who is unwell function the best way she or he can? How can you maximize her quality of life or his quality of life the best way? So that's one of the driving forces of geriatrics, right? This is the other sad part, is that many people either don't have access to medical care or ignore what's going on until it gets too late, to a point where conditions that are completely reversible and treatable are often either underdiagnosed or undiagnosed or not treated to the extent that they could be. So geriatricians want to correct that. And as I mentioned with the gerodiversity, our social history and support and the preferences of the patients, what do they define by quality of life for themselves, are essential aspects of managing patients. There is no one size fits all in this case. Right? We've already talked about this in Rakhiji's talk. Cognitive and affective disorders are quite prevalent, and quite frequently we don't know about it. We don't notice them until they're progressed sufficiently. Iatrogenic illnesses, and this is a term that derives from when a doctor tries to treat us with for something, they cause some other condition, right? The most common definition of most common um, um, example of this is interaction of one medication with another. So these illnesses that derive from the attempt to treat us are quite common. Many are preventable. There is no one specialty that helps treat older people. It's multidisciplinary. You require therapists, you require doctors, you require social workers, you require dietitians, psychologists, and so on and so forth. And it can be provided in a variety of settings, from being at home to having to be admitted to long-term care, depending on what the patient has. And again, especially as when they grow older and maybe they have dementia or no longer able to advocate for themselves, ethical issues and end of life care become critical aspects of the practice of geriatrics. Pointed to some of this. This field of elder care is crisis driven. It's not something that you do on a daily basis. You don't go to a doctor unless you're unwell. Sometimes you don't go to the doctor even when you feel unwell because you feel there are other priorities that you have. But the message that I want to convey to you is that to the extent that you can avoid reacting only in a crisis, to the extent that you can start early and plan ahead, your quality of life and the impact on your family and your friends can be minimized and your quality of life can be maximized. So organize your thoughts, organize your actions, start early, and understand that things can change very rapidly in a situation when in this. The next part of this talk, so that kind of gives you a background. The next part of this talk, I'm going to be giving you some tips on what are the things you can do so that you can provide the best care for the older person. And this is now a focus on the person receiving the care, right? We'll talk about on the caregiver in the next talk. So think of a number of different things. The safety. How do you coordinate the care across 2 or 3 disciplines, across 2 or 3 illnesses, 2 or 3 different doctors, specialists, and so on? Not all people have a primary care physician who looks at all these aspects and does the coordinating for them. People just sometimes frequently just go from one specialist to the other, and the exchange of medical information isn't always perfect. So we need to be advocating for ourselves and for our family and making sure our care is being coordinated correctly. Think of what's of value for that person in their daily life and maximize that functionality, maximize that quality of life the best you can. We've talked about diet in the last talk. Think about the diet. Think about their hygiene. Are they able to take care of themselves well? What help, what assistance do they need? Do they have memory issues? How can you assist with them with that? What are the memory aids you can provide them? What assistance do they need? And so on. Are they able to move around the house? Do they need a walker? Do they need help driving from point A to point B? What sort of help do we need in terms of maximizing their mobility for the life that they need to live, right? And then we need to learn about different things. There are 2 terms that you will see people use in the profession One is called ADL and one is called IADL, activities of daily living and instrumental activities of daily living. Very simple to understand. Activities of daily living are all the things you and I do to look after ourselves every day. We get up in the morning, brush our teeth, take a shower, change our clothes. If we need to, we can cook our own meals, take care of ourselves. What are all the things we need to do to look after myself? Those are my activities of daily living. The instrumental activities of daily living are the activities one needs to do not to look after oneself, but to live in the community. So make appointments, make phone calls, drive, go to a bank, write a check. All of the things that you need to do as functional members of society are called instrumental activities daily living. So people are categorized in their ability, in their functionality by how do they perform an ADL, how do they perform an IADL, when and where do they need help on one or both. So you need to be familiar with that way of thinking about things. Then in this kind of a society, you need to understand whatever medical and other insurance coverage people have, life insurance, long-term healthcare insurance, whatever it is. Understand the finances well. Rakiji talked about finances as a critical part of looking after those with dementia. If you had to pay for care, a nurse or a aide or a nanny or somebody to come help for a few hours, what does that cost in your community? What supportive resources and groups are available in your community? Be aware about that beforehand so that you're not responding to a crisis when it happens. Plan for your family yourself. Set up a network of care so that we know for each other what are the things we need to do when the time comes, right? Do I for one want to live in my own house independently as long as I can. But what happens when I'm no longer able to do IADL or ADL? What happens to my housing then? What are my options? Who will take care of my finances for me? What are the financial, legal, etc.? How are things going to be paid for? Does my insurance cover everything? Do I need to borrow money from my retirement or savings funds to cover things? What are the options, right? Those are things we need to understand. Then look at the system of care in your community. What are the hospital systems? Where are the emergency rooms? What are the rehab centers? Is hospice and palliative care available? Just understanding that community and knowing where the resources are going to be, it's helpful to plan ahead and think about all of these things, right? And we as Indians, South Asians, typically don't like to do this. We're very private people. We don't want to talk about our issues, but at least within a small core group of family or maybe friends, have meetings, discuss these things so we're all on the same boat. It really works well rather than having to do it in a crisis situation. A lot of us are dealing with adult children. A lot of us are dealing with adult parents. A lot of us are dealing with young children. And with this family construct, there's a lot of juggling you have to do with your work, your activities of daily, your own activities, daily living, your friendships, your extracurricular activities, when you have caregiving and other issues thrown in. So sometimes you have to deal with role reversal. You have to, it's like this little cartoon on the right. You're juggling several balls in the air. What do I do next? Should I look after my spouse, my kids, etc.? Sometimes there's a lack of common ground within the family. You don't all think alike on certain things, right? So it helps to have a discussion. It helps to figure out having a coordination plan and on tips on dealing with the medical system variety of other things that would help you when you have this elder care issue that you have to deal with, if you've got a plan in place to work it, right? Understand what the challenges of the system are in your community in terms of staying well, in terms of preventative care, in terms of dealing with illness. And I've talked about these, the clinics, the hospitals, the rehab facilities, and so on. And there may be issues in your area where there are gaps in the system. So how do you, if you had to deal with this, how would you propose to do it? So understand what the potential challenges are in the system. Right? Okay. And so here's a list of proactive planning areas. We've addressed some of these in more detail. Some of these are lectures by themselves, but understanding the health condition, the safety aspects, housing, having a transition plan for housing if needed, right? Legal and financial issues, getting a good grasp of all the resources you can energize and bring in your on your behalf, and a good um, support within your own community are all the some of the things that you might want to address. All of you may not have all of these issues. Some of you may have to pick one or two, three of these areas and do some more detailed planning. But this generally is a list that professionals suggest that when you're dealing with old age, be aware of all these things and plan for them. Okay. I'm going to be talking about caregivers more in the next lecture, but you have to understand that within a family circle, anyone can be or anyone can become a caregiver, right? You can be a patient, you can be a caregiver, the roles can be reversed. And it can be within the house, it can be for a couple of weeks in a hospital, it can be for rehab, it can go all the way to end of life, looking after a person until he or she passes away. And the different people play different roles. So being ready for these transitions um, is important, and I'll talk about this more in the next lecture. Okay. This is again a topic that I will leave for more discussion, but look at this from the point of view of the patient. A patient has to understand that caregiver has to deal with stress as well. Did they make a choice to be the caregiver, or was it a de facto thing, right? How can I, as a patient, given all the things I'm dealing with, if I'm able to, how can I relieve that caregiver of the burden and be supportive of the person looking after me? What are the family support and dynamics that I can, if I'm able to bring uh, to bear to help the person looking after me? So those are again some of the questions that we want to think about and address, right? I talk about this in terms of caregivers, but this applies to both the caregiver and the patient. You have to know about yourself, what your goal in life is, how you respond to day-to-day situations. Are you focused on the task, or do you want to avoid confrontation? Are you worried more about maintaining happiness around you? You know, what drives you? Understanding how you behave will help you then in turn provide the best care to other people, right? And all of these questions, we know each other if we've lived as a family together for many years, but all of these questions sometimes are not discussed amongst one another, and that creates conflict. And conflict is one of the things we want to avoid when we're looking after someone who needs our help. So these are some of the tools that we can think about in terms of listing for ourselves and learning to understand um, how to maximize the situation for everybody concerned. Okay. Rakiji talked about this to some extent. We have to be proactive in maintaining both our physical and mental health. She listed several different factors: diet, exercise, social construct, etc., etc., etc. The Center for Disease Control has a number of detailed references that help you develop your own checklist and develop your own routine to maximize your health. And as I'll talk about it in the next lecture, while we're talking about this in this construct for people growing old and being unwell, it's important for the caregivers as well. Right? Here are some links that I have for that have resources on elder care. Avenidas is a local organization in the Bay Area that have a number of excellent resources. The National Institute of Aging is a federal government institution that has some excellent resources. For the Family Caregiver Alliance and Elder Care Locator and Lots of Helping Hands are community service organizations that have a national footprint. And then locally here in the Bay Area, the Stanford Hospital has an aging adult services program that provides help in a variety of different ways for elder care. So here are some of the resources which might help you if you want to go further down the journey to understand this some more. Okay, and again, there are some links in the document that I can that I'll leave with you. You can look at these at your leisure. And with that, I will stop share, and I'm open for questions. How am I doing on time? Any questions, any comments, any thoughts? Floor is open. Rita ji?
Yes. How can we find out about the private care and community supportive things? And you gave for the Bay Center, right? But all over in United States,
Right.
is there any special things like for nationwide or things like that?
There are some couple of the links that I gave you in the document, like the elder care locator and so on.
Yeah, I saw that.
You can actually enter a zip code,
Uh-huh.
and based on that zip code, they will give you resources. Usually, the county that you live in has a county elder care services. That's an excellent resource that you can start with as well. But talking to if you're within your healthcare system, your primary care physician or a specialist is sometimes a very good person to contact to say, give me some links or references in the community to go for the specific things that you're interested in. But I would say if you start with those 2 or 3 things, you will then very quickly get more information on what your specific needs are. And if you have looking for specific information, if you sort of send me a text privately, then I can try and see if I can find someone in your area to help you with that as well.
Thank you so much.
Seemaji?
Yeah, namaste everyone. I just wanted to share some information based on which was raised in a previous session. That there is definitely shortage of resources for aging population specific to Indian community. The needs of Indian community are different, but there are few out there. For example, Priya Living Senior Services in California, they have 2 locations which are tailored for Indian community. And then I believe last year in Washington DC metro area, the former president of Seva International has opened a daycare for seniors where a working couple can drop their senior parents where they can socialize and during the daytime, just like daycare for children, and they can drop them and then pick them. So they don't have, while they're at work, they don't have to worry about their whatever food or other needs or being lonely or something like that. So I just wanted to share these 2 points. One is a couple of resources which I am aware of, and there's definitely a need and shortage of some resources or housing which caters to Indian community needs, because there are obviously cultural differences, and the local senior care centers do not cater to Indian community need with respect to food, culture, other issues, and of course they are phenomenally expensive also. So
that's right. A couple of comments, Seemaji. Thank you for that. So in the Bay Area here, you have the India Community Center that also runs a couple of senior centers, 2 or 3 now, in fact, in different parts of the Bay Area. But of course, with the pandemic, all those activities have temporarily come to a stop. There also were a couple of efforts to have enough people come together to actually build a senior community for Indians, but for financial and other reasons, so you're definitely right. For people looking for that sort of arrangement, there is a lack. So I guess the question we have to ask ourselves is, in the next 5, 10, 15 years, if that's not there, what's the best thing we can do? How can we as a community adjust and support each other? Are there ways of building groups within our own local communities that can manage to do that? So there's a lot of discussion and activity that needs to happen at that level. And maybe that's one of the things some of you as community service can think of in your community going forward later on in the next few years. Take an active role in leading that effort to help bring some level of commonality that includes our culture, our heritage as much as possible. Those are some of my thoughts.
yeah, can I make a counter comment?
Sure.
Yeah, so Mukunji, I know that you mentioned about financial constraints, which are, you can say, prohibiting such initiatives. But I mean, with due respects, Indian community is one of the most successful community, and people have plenty of money. So I don't know about that, and especially in Bay Area. So it's, and I mean, I am aware of people who have like hundreds of properties out here, within the hands of few people, So it's just like, it's called redirecting the resources properly, So, or maybe, I don't know, whether they don't see the value in it or they don't have lack of interest. It could be anything, The only challenging part is this whole insurance issue in America, the liability factor. But other than that, I do think Indian community has lots of, is a wealthy community, in my opinion, so.
It is. There are, as you said, some very, very wealthy people, but I also know personally several Indian families who are having difficulty making ends meet. So it's the diversity of the Indian community in terms of socioeconomic status has, at least in the last 10-15 years, changed quite a bit all over. But that's a discussion of its own, Seemajis. But your
Yeah,
point
right,
is,
right.
yes.
Yes.
How are we doing on time, Anita ji?
Yes, 5 minutes behind.
So are there any um, recent experiences that you know of that you would want to share with the group that that touch upon the topics that we've discussed, that would point to, for example, the lack of if you, in retrospect, if one had planned a little better, things might have worked out better. Any such experiences that one would like to share? Rita ji?
Oh, yes. I was just thinking, I think Srimaji said, right, about that Indian community has lots of money. Um, Last year, I met one of the guy and he was working for IBM, very good position, good money making and everything. And they took the early retirement and then the sickness comes, in the both of the family. It's lots of hospitalization and lots of expense, and they have to take out the money from their pockets and all kind of things. And this is, they are very broke. I heard from a couple of people. And maybe the way you said, maybe it's a poor management you can call, or I have no idea their situation, what they were doing and how they were planning. But sometimes the way they were talking and what I heard, uh, all other expenses, like, after they get retired, all the hospitalization on and off, both husband and wife and everything. So they got drained up with the money.
Yep.
Major sickness, major sickness drain you up, no matter how much money you have and everything. But sometimes that's what they were telling.
Yes, if you don't have the right kind of health insurance, it can put you in financial trouble. You're correct. Nishta ji, you had a comment or a question?
I actually had a comment and I was going to share. As I mentioned, I volunteer with a couple of Indian senior groups here. And one of the things which keeps on coming up is the loneliness that they all feel. And I had sent you a message offline regarding that. So what we're trying to do, because I looked at some of the other non-Desi groups, so what we're trying to do is set up some sort of a check-in phone call to these seniors, and just to just communicate with them, talk to them about different things, and just have them feel a little less isolated. So I think it would be great if we had something like this at a larger scale, where the person who's calling could talk in Hindi, in Gujarati, or in some of the other languages which are most prevalent, and just and even get some of the younger seniors to make the phone calls, but just do a health check-in. I think it's called a wellness check-in, and it's a phone. You basically are calling like 10 people and making sure that all is well, because they feel less isolated. And if there's some seniors here who have no kids. It's just the husband and wife, In one case, the wife has got Alzheimer's, so the husband feels really isolated. So I think that would be a great initiative to do even nationwide, where we had volunteers who speak the various languages.
I couldn't agree with you more. Yeah, that would be a very valuable service. Thank you for that. Imaji?
Dr. Mukundji, if I can share.
Yeah, I just wanted to add to what Nishtaji said, and Mukundji, you mentioned about smaller localized effort. So I just wanted to share one more piece of information. Like in Fremont, we have a senior care center, even though it is a city-driven program, but within that city-driven program, a person is managing a senior group of maybe 50, 60 people who are all desis. So it caters to like their needs, and the activities revolve around their needs, and they meet once a week, and parents, meaning they can come to that common location, they get free lunch, and then they do certain activities including yoga, prayers, whatever, so these type of efforts can also address the loneliness problem to some extent, as long as they are reasonably fit to come to a given location.
Yeah, thank you, Mahaji, and then Ritaji.
Thank you, Dr. Mukundji. You were specifically asking if we have had experiences and we have learned something, a thing or two, and I'd be most happy to share that with the recent, crisis that we had in our family with my father going into respiratory distress. We come from a family of many doctors, and yet, in our situation, we always positively think about our parents, that nothing can happen to them. And even though we have discussed certain things, in some ways I feel like when my dad was ready to come back from the ICU to home, as excited as we were scrambling to find out and set up the care at home, because we knew realistically it cannot be just us, it has to be someone else as well that's qualified, like a nursing assistant. And having been away from home, India, for a long time, even though we visit regularly, these are things that we didn't look into. Maybe romanticizing that our parents will be there forever, and not trying to put ourselves down. But I also wish one thing that retrospectively that we could have proactively just looked into the area, like you were talking about, Dr. Mukundji, that are resources available. I'm sure in India perhaps it's harder, but it's there. And when when the fire is not already up there, we could just have also looked into what are the local resources, if we needed home care for our parents, what could we do, those kind of things. And although we were lucky to find things, it was a struggle for about a week, trying to get the right care, references, etc., etc. So in the US, as you pointed out, there's so many resources to know, at least for those families who have elders close by or at home or even far away, to proactively look for that will be helpful. So if a fire had to come out, to put it out or to be part of a productive healthcare team, it will be a little bit more easier or a smoother transition.
Thank you, and I appreciate the fact that you're sharing the personal thing that's going on right now for you and your family. That's not easy to do sometimes, but it just points to just the logic of it, right? If you know that something is likely to happen, if you are better prepared for it, whether it hopefully it doesn't happen, but if it does, you're better prepared to deal with it than dealing with it in a crisis mode. And that's just the general message that I was trying to convey with this. And then identify in detail what are some of the areas that you have to look at. So hopefully that's clear.
Absolutely.
Any other questions or thoughts? I'm not keeping track of time, Anita ji, so you have to let us know